Good morning, Professor Bargman. I think you're mute.
Yeah, I just unmuted. Good morning.
Good morning. Good morning. My name is Ahad. I think I've been in sort of emailing you and bothering you for the last couple of weeks.
Nice to meet you.
Likewise.
Hi, Nayar.
Yeah.
Hi, Dr. Bargman. How are you?
I'm fine. How are you?
I'm good. Fine.
Yeah.
Yeah, it's too early in Toronto, I think. It's, but I think you are early bird.
Yeah. Yeah. It's coming up on 9 o'clock in the morning.
Okay.
How do you get people to attend on Sunday night?
Yeah, actually, in here in the Pakistan, most of the people, they are busy in their practices on the working days, in the evening practices. So it's better to organize a meeting on a weekend, and people like to attend actually on the weekend. They have a time on that day. Yeah.
I mean, Sunday night, you're probably just trying to relax. And I really admire people for wanting to attend a conference at that time.
Yeah, really.
Yeah, but actually, because we run this CME program once a month, and it's usually based around the United States time. So all CME activities are actually planned for 10 p.m. Sunday night for Pakistan, because it's early morning in the US. And yeah, so that is usually the ideal time, and that's where maximum. I'm sorry to bother you on a Sunday yourself, but that is when you get the maximum attendance for Pakistani nephrologists.
I'm just amazed that people would attend a conference at 10 o'clock on a Sunday night.
Yeah, absolutely. And it usually goes till midnight. Usually more often than not, it's till 12 and midnight then. Yeah, absolutely. Because you stop at 11:15 and then questions for 45 minutes. Yeah.
So this is relatively early for you, I guess, 7 p.m.
Absolutely. Absolutely. This is a decent hour for us. Yes.
Okay. So I have to figure out how to share my screen and everything, right?
Absolutely. So we're just waiting to start. Let's just wait for 6 minutes. Is that all right? So because we've told everybody to join in at 7, and we're also recording, so we will be sharing it through the website as well.
Okay, but I just want to make sure there's no glitches.
Yeah, sure. So, by all means, go for it.
Okay, so can I put my my talk up?
Absolutely. Absolutely.
Okay, let me do that. Okay, do you see it?
Yes, we do. Yeah, absolutely. Yeah.
Okay, good. And I'll make it, when we're ready, I'll make it full screen.
Absolutely. Absolutely. That's fine. That's perfect.
Okay, good. It's kind of case-based. And I mean, it's too difficult, I find, over Zoom to have people answer, but I'll just let people think about answers while I'm going on. I think that's probably more engaging.
Absolutely. Absolutely. If it's interactive, that would be much more better that way. Absolutely.
Well, people are welcome to interact if they want, but I've just found it gets a little bit awkward on Zoom to try to do that. But if people want to use the chat function, it's just I can't really give the talk and monitor the chat. So maybe you will have to do that, okay?
Absolutely. So myself and Nayir will do that. And we'll also have Professor Nomantari who will be looking after that, and we'll just sort of take questions right at the end.
Okay.
Yeah.
Perfect.
Or if you want to do and we like to do it like in between an interactive session, that's also okay. It's up to you. It's how you feel comfortable.
Well, you know what I can do is pause and say, are there any questions? And then if you probably people may be too shy, but if you're monitoring the chat and you're the moderator, if you want to at that point bring up anything, that's fine too. If not, I'll just go on.
Okay.
Does that sound good?
Yeah. Ahad, you will be monitoring the chat. I think you are the host.
Okay, sure. I'll monitor the chat, and yeah, absolutely. Let's just do it that way. So whenever you're comfortable, you can just ask that if are there any questions, and if I can see anything in the chat box, I'll just or they can raise their hand, and I'll address that. That would be
okay.
perfect.
That'll break it up nicely.
Absolutely, absolutely. So we'll just wait for 4 more minutes, and then we'll start. Yeah. So people are logging in.
So Nayar, what are you doing with yourself these days?
Ma'am, I have joined Multan Institute of Kidney Diseases. It's a good setup, around 150 bed hospital. So we are now starting a PD program there. I think just two patients are ready. Now we are planning to put the PD catheters. So you know the people are not trained and we have to start from the scratch. So kind of like it's a difficult time period for us at the moment.
Is PD affordable?
Yeah, so the government of Pakistan, it's actually funding this project. So they have given us like 24 patients budget per year. So to start with, and then as long as we go ahead, people will be trained and they may give us more budget to put the patients on the PD.
And
Like-
where do you get your solutions from?
So right now the Fresenius will provide us the solutions.
And it will be cost effective compared to in-center hemodialysis?
Yeah, so if you compare the in-center hemodialysis is almost equal expense. PD and hemo are both are equal at the moment.
Okay.
Yeah, it's a
Good.
huge burden actually on hemo.
I'm
Long
sorry, say that
waiting.
again?
It's a huge burden on the hemodialysis machine, hemodialysis center. It's a
Right.
lot of people waiting for that.
Right. And you said you've had John Crabtree talk already?
Yeah, we last month, John Crabtree, he talked about surgical perspective of the PD catheter insertions and some troubleshooting with that. So I think this talk is a nice follow through
Yes.
from
Yeah.
the nephrology perspective. Yeah.
Do you have any other PD talks coming up?
Yeah, we are planning like every month we will do that. And even if you could like help us in other subjects like core curriculum of the PD, few of the lectures, if you could deliver us, so that would be nice as well.
Sure. Okay.
Yeah.
So the way that it's working at the moment is that through the PD Academy of Pakistan, we're actually on a monthly basis, we're asking like a global leader like you very kindly yourself to join in and sort of give us that perspective. We're having a lot of problems with our catheters, which were placed surgically. So that's why we asked John Crabtree and we asked our surgical teams from respective hospitals to join in. Earlier, I think this will probably be followed by Edwina Brown. I'm pretty sure that you know her, Edwina, from Imperial.
Yeah, sure.
Yeah. And I think we were also in talks with Fred Finkelstein, who did visit. Edwina Brown and Fred Finkelstein actually visited Pakistan about a couple of years ago and kickstarted our program. I think Nayar hadn't introduced us, otherwise we would have brought you across to Pakistan at that point as well.
Yeah, sure.
Yeah.
What's she going to be talking about, Edwina?
So she wants to talk about prevention of peritonitis and how you can treat it, but it's going to be more around prevention than anything else, because the next Achilles heel we have is to developing a PD nurse program.
Yes.
So we've got HD nurses, but we don't have dedicated PD nurses. We're just going to try to develop a curriculum around that, and what are the minimum requirements for somebody to certify that this is a PD nurse and they can go ahead with it.
That's a great idea. The problem is it's like a circular argument, like you need a decent mass of patients to justify having a dedicated PD nurse, but it's hard to get a decent mass of patients unless you have a dedicated PD nurse.
Absolutely, you've hit the nail on the head, because that's the problem we have with even asking from a commercial perspective to ask whatever company to invest in peritoneal dialysis. What they say is that you need to have such amount of patients and then we can subsidize peritoneal dialysis. So it's sort of if the egg came first or the hen came first. So that's also that sort of a question.
Exactly.
Yeah.
Even American units struggle with that.
Yeah.
And if you try to start a PD unit and you use a hemodialysis nurse part-time, it's not ideal. You really need to be dedicated.
Absolutely. Right. So if you think, if you're ready, can we start? Yeah.
Sure, of course.
Let me just introduce, let me just formally start the program. Right, so Bismillah ar-Rahman ar-Rahim, Assalamu alaikum. My name is Dr. Ahad Qayyum. I currently chair the PD Academy of Pakistan, and this is a CME activity under the umbrella of the Pakistan Society of Nephrology. I am once again very, very grateful for all those who are joining in, and then we'll also be reviewing this on the website. So without further ado, let me just introduce the moderator for this activity. This is dare I say, he's a very, very good friend of mine, Dr. Nayyar Salim, who had the pleasure of training with at Sheikh Zayed Hospital, Lahore. After doing his FCPS in nephrology, he moved to Saudi Arabia for a little while, got the specialization from there. Also, apart from Pakistan, is a member of the Royal College of Physicians and has had the honor and privilege of getting a fellowship, a 2-year fellowship at the University of Toronto, and with our guest speaker. So Dr. Nayyar, over to you, if you can just take the dice. Yeah.
Okay, thanks, Art. Thanks for this nice introduction. So I would just like to take this opportunity to welcome everybody to this series of webinar, which is mainly to help clinicians to develop sound knowledge and principles of peritoneal dialysis. Our vision is to bring together nephrologists and policymakers and allied healthcare staff to come up with the solutions we daily face in our clinical practice. And following from the Dr. Crabtree lecture, it's a nice follow-up lecture regarding the PD catheter problems and solutions. And I know, and you as well, that as a practicing nephrologist, there's no more a frustrating challenge that having a patient ready for training and catheter is not working, and the solution's going in and it's not coming out, or neither it's going in nor coming out. It's really frustrating. This challenge, we have organized this webinar with a particular emphasis on the catheter-related problems which nephrologists face on their daily practices. And to address this issue, I think there is no one better than Professor Joanne Bargman. Dr. Bargman is a staff nephrologist and professor of medicine at the University of Toronto. After completing her senior medical residency year at Melbourne, she completed her nephro fellowship at Stanford, and upon her return, she worked with the legendary Dr. Dimitrios Oriopoulos in Toronto Western Hospital. Currently, she is a director of PD program at UHN. She has been a president of International Society of Peritoneal Dialysis from 2012 to 14, and is also a co-director of Renal Rheumatology Lupus Clinic. She has gained numerous awards for her excellent teaching, mentorship, and excellence in nephrology research, which included 2015 Lifetime Achievement Award in New Orleans, and most recently Robert Narins Award at JASN this year. Over the decade, she has been involved in training of hundreds of nephrologists, including myself, and many of them has pioneered their own individual peritoneal dialysis units in their countries of origin. It's really a remarkable achievement on her part. I really welcome her, and looking forward to learn something from her. I will now give floor to Dr. Bargman. We will keep this question and answer session at the end, but however, if anybody wants to interrupt and wants to ask a question, Dr. Bargman is happy to answer that. Over to you, Dr. Bargman.
Thanks, Salam Alaikum, and thanks very much, Nayyar. I echo what you said. There is nothing more dispiriting than telling someone all the virtues of peritoneal dialysis. They agree to it, you put in the PD catheter, and then it doesn't work. And it just really can be very demoralizing for the patient, for the family, for the doctors, for the whole unit. So I hope that this talk helps to educate a way to try to work your way through the problem with the PD catheter. So you've probably seen a lot of these. This is American data that looks at reasons why people transfer out of peritoneal dialysis to hemodialysis in the first year of therapy. And you can see that a significant piece of the pie is because of mechanical problems with the catheter, a significant loss out of peritoneal dialysis. So Dr. Crabtree probably went through this with you, the different methods of insertion of the peritoneal dialysis catheter. He, as you know, is a big fan of advanced laparoscopic techniques, and we are too. In my program, we have someone who trained with Dr. Crabtree and uses these advanced techniques that really help to improve the success of the catheter. So the first issue, and I'm sure he brought it up, is whether you have a surgeon who is trained in these different laparoscopic techniques, because it really is so much more important that the surgeon be able to see where the catheter is going inside the peritoneal cavity so that they can do things like take away adhesions, do omentopexies, and things like that. And there's a lot of data, and it may be subject to publication bias, but it does suggest that the complications that we really don't like to see, such as obstruction of flow or flipping of the catheter tip, are much less likely to happen if advanced laparoscopy is done that way, rather than putting in a catheter just with basic laparoscopy. And probably both of these are better than a blind surgical technique where the catheter is just really advanced by feel without direct visualization of where it's going. So these both suggest that these advanced laparoscopic techniques do supply a benefit even over basic laparoscopy. The percutaneous catheter insertion is another way to do it. It's certainly a lot easier to do. Certainly in my program, it's hard to get operating room time to do laparoscopy. I don't know what it's like where you practice. If it is hard to get operating room time, then sometimes there's a benefit to doing it percutaneously. But again, that can be a lot difficult. It can be done by the nephrologist. It can be done by interventional radiology. And there are some techniques that can't be done this way, cannot be done this way, that can be done with the advanced laparoscopy. Now, my colleague Matt Oliver has started a North American PD catheter registry. And this is some of the things that he found. Not a ton of operators, but still over 50 centers. And you can see that with the percutaneous insertion, for example, there's more midline insertion. That is because probably there's a lower risk of bleeding at the bedside if you put it in the midline. However, the midline insertion is associated with a higher risk of leak. Things like rectus sheath tunneling, which I presume Dr. Crabtree talked about, are more easily done with the laparoscopic than it is by the percutaneous. And putting a purse string suture in the deep cuff of the catheter is more easily done with the laparoscopic insertion compared with the percutaneous insertion. Interestingly, we tend not to do percutaneous insertions with interventional radiology when there's a history of previous abdominal surgery, but not all other units go that way. And you can see in the bottom right box here that for the percutaneous insertions, about a third of the patients had previous abdominal surgery. So again, it probably is a comfort level, and it probably also depends on the extent of the previous abdominal surgery. And here's another comparison between percutaneous and laparoscopic insertion. And again, there's a lot of variability. They were small studies, and again, may have been subject to publication bias. So it's really hard to know what to make of these kinds of comparisons. I am certainly a big fan of advanced laparoscopic techniques. Ever since Dr. Penner learned the techniques of Dr. Crabtree, we have got excellent PD catheter results. So if you're starting a program, it's really important that who's ever putting in the catheters knows what they're doing. And I don't know if Dr. Crabtree showed this picture to you, but this was a patient that the PD catheter was put in by another surgeon and the catheter wasn't working well. So they sent the patient to Dr. Crabtree. And the first thing he noticed was that both the cuffs, you can see on the left side of the picture, were outside the patient. So here's the superficial cuff. Here's the deep cuff, which should be deep in the rectus muscle. And it was clear that whoever put in this catheter had no idea what they were doing. And that's why, of course, the catheter wasn't working, because it wasn't put in at all in the right place. And here's another picture from Dr. Crabtree. The superficial cuff should be inside the tunnel, at least 1 to 2 centimeters away from the exit site. But you can see that the superficial cuff was put right at the exit site, and it just started eating away at the tissue. That is never going to heal. That's going to get infected, and the patient is going to lose the catheter. So this is another incorrect way that a PD catheter was put in. And Dr. Crabtree probably showed you this too. By convention, there is no suture put at the exit site because that limits healing and epithelialization of the exit site. And what you can see here is a tight suture put at the exit site. Again, whoever put in this catheter didn't read the literature and didn't know the right thing and the wrong thing to do about putting in a catheter. So I'm going to show you some of my patients. Here's someone who had renal failure postpartum. There were no live donors. She attended an education class and chose peritoneal dialysis. And in this case, before Dr. Penner started doing the advanced laparoscopic technique, the catheter was put in just by feel, like a Seldinger type of technique. She came to the unit to begin training, and the dialysis fluid went in okay, but it was a very slow outflow, something that Nayar described in his introduction. So the first 500 mils took way too long to come out, and then the flow just stopped altogether. So what would you do with a patient like that now? Would you turn her on one side and the other side and see if you could find a sweet spot where the outflow resumed? Would you flush the catheter vigorously with heparin? Change her to hemo? Obviously, PD isn't going to work in this patient, or obtain a flat plate of the abdomen. So think about that, because, you know, if you start a PD program, this is something that is very likely to happen. And, you know, if you have a good PD nurse, the PD nurse may already do some of these things, such as turn the patient on one side and the other to see if you can get the flow to go better. The nurse might try flushing the catheter vigorously with heparin, although that flushing with heparin is usually better for inflow obstruction, not for outflow obstruction. And if you know my talks, you know that option C, changing to permanent hemo, is always the wrong answer. So you really have to think about catheter problems in terms of two-way and one-way obstruction, because they have very different approaches to diagnosis and treatment. And two-way obstruction means poor inflow, poor outflow, or no inflow, no outflow. And one-way obstruction is the more common problem with good inflow, but poor outflow. But you really have to stop and say, okay, which one am I dealing with now? What is not necessarily a problem, just as a side point, is a different scenario. This is different from the patient one I just showed you. Sometimes you get a patient and you put in a liter and there's good outflow and 500 mils comes out just fine, but you don't get the whole liter back. Why is that not necessarily a problem? And what would you do next about that? This is important. And again, a good PD nurse may just do this automatically. Well, the reason why a liter went in, but only 500 came out with good flow in each direction may be because there's a dead space in the peritoneal cavity, the pericolic gutters and places like that. And maybe 500 of the 1 liter that went in just went into those pericolic gutters and therefore is not available to drain out. So what you would do next in this particular scenario is to infuse another liter of fluid and therefore make sure you have filled up all the dead space, and then you're working with a retrievable amount of fluid that can go inflow and outflow. So I just want to, as a side point, say that this particular scenario with good inflow and good outflow, but you don't get everything back with the first ever exchange, is not necessarily a problem. And just put in more fluid and see if you just fill up the dead space until you have a working volume of inflow and outflow. Two-way obstruction, nothing goes in, nothing comes out, is usually an intraluminal problem. And that can be because the lumen is obscured because of a kink or a bend in the catheter, or because something is clogging up the lumen of the catheter. And that can be a hunk of fibrin, or it can be a blood clot or something like that. It's very important that whoever puts in your PD catheters, especially if it's surgically, make sure, and I'm sure Dr. Crabtree talked about this, that you make sure that there is good outflow at each step. When you put in the PD catheter, then when you tunnel it, and then you have to make sure before you say that this catheter is complete, that there's good inflow and good outflow. And that will make sure that there isn't a kink in the catheter that you then have to deal with. So what do you do if in the unfortunate incident there is a kink or bend in the catheter? Interventional radiology under sterile conditions can try to insert a trocar and straighten out the catheter. Sometimes that will work, sometimes it won't. If there's a blood clot or fibrin in the catheter, there's something called suck and flush, where you can put a syringe with heparin in it, and you suck and flush in the catheter to try to pull out fibrin. And sometimes too, you can use heparin or TPA for an intraluminal clot or fibrin. Again, proper insertion of the PD catheter, the surgeon should load up the dead space with heparinized saline so that you don't get this kind of fibrin clot. And here's one of our patients who did have two-way obstruction, and our nurse was able to suck and flush and pull out this fibrin plug. And I just want to show you the most amazing fibrin plug you'll ever see. This was a coiled PD catheter that was a buried catheter. And when it was exteriorized, there was no inflow. And the patient had to eventually go back to laparoscopy, where Dr. Penner was able to tease out this amazing fibrin plug that was the whole PD catheter. You can even see where the holes in the PD catheter were, their little fibrin spikes here. So this is the kind of problem you don't want to have to deal with. This is a catheter dye study that shows dye going through the catheter, and then all of a sudden the catheter makes a sharp turn here. And this has occluded the lumen here, or really slowed down the flow of dye through the catheter. So this is a kink in the catheter. A trocar was put in and straightened out the catheter, and there was better flow, although you worry about the long-term success of this catheter given the tight bend in this particular catheter. But that is something you can do, and sometimes it will work. As I said, though, the more common problem is one-way obstruction, good inflow, but poor outflow. And the commonest cause of this commonest problem is constipation. So we nephrologists, besides now becoming experts in lots of other stuff, like hematology and so on, have now had to become experts on how to relieve constipation. So you should have some sort of protocol for relieving constipation. And that really is a big problem for these patients. Other causes besides constipation is that the catheter may have flipped up into an upper quadrant or into some sort of loculated pocket. And if the catheter has flipped into an upper quadrant, the fluid will still go through the catheter into the peritoneal cavity, but it all falls into the lower quadrant or not easily accessible to the PD catheter. And that's why you have very poor or temperamental outflow. The other thing is an omental wrap. So both constipation and omental wrap, the fluid sometimes can come out of the catheter into the peritoneal cavity, pushing away the constipated bowels or pushing away the omental wrap. But when you go to outflow or drain out the fluid, the bowel or the omentum sucks up against the catheter, and that's why you have poor outflow. So that's really why you see this syndrome of good inflow, but poor outflow. And Dr. Crabtree probably showed you this picture. This is a coiled catheter. And one of the purposes of the coiled catheter is to stop omental wrap. But you can see nonetheless that there is an omentum that has wrapped itself around this coiled catheter. So back to our patient, the postpartum renal failure patient who had good outflow, but good inflow, but bad outflow. What would you do? And really, I think the best thing here would be to obtain a flat plate X-ray of the abdomen. It's certainly not a bad idea to turn on one side and the other to see if there's a particularly good spot to get outflow. And like I said, a competent PD nurse would do that anyway. Flushing the catheter with heparin would be better for poor inflow rather than outflow. And of course, C is not the best answer. So here's her flat plate of the abdomen. And this is what you will usually see, is that there's lots and lots of stool in the abdomen, and the catheter tip, I don't know if you can see it, is pushed up into the abdomen, into the middle part of the abdomen. I really can't see it on my side, but take my word for it that the catheter tip has been pushed up into the middle quadrant of the abdomen. So what would you do now? And I think the best answer here is to try to get rid of the constipation by pressing forward with laxatives and cathartics to try to clean out the bowel. So I think that's the best answer. I wouldn't go directly to manipulation because first of all, it's harder to manipulate the catheter and it may be prone to complications if there's loads of stool-filled bowels. So I think the first order of business is to clean out the bowels. And sometimes just with the correction of the constipation alone, the catheter will find its right position back down into the pelvis without having to resort to some sort of manipulation. So the patient is given a lactulose and a tap water enema, and you're told that there are good results. So the next question is, are you happy? And the answer is not necessarily. And why aren't you necessarily happy? Because good results may just be that she emptied the rectum and had one bowel movement, and that's great, but that may not be enough. And there could be 15 potential bowel movements lined up behind that one. So that doesn't necessarily mean that we're finished trying to get rid of the constipation. So press on with the cathartics. The patient is sent home for the weekend with lots of cathartics. She has loads more bowel movements. And I want to say that in truth, this is usually where things start to improve. And usually what you see is that the patient comes back and there's better outflow and things gradually improve from that point on. However, in this particular case, for the point of education, there is still no improvement in the outflow. So you've taken care of constipation, but there's still poor outflow in this particular case. What would you do next? And again, I don't think, because this is a problem of outflow and not inflow, I don't think flushing the catheter is going to do much of anything. And my best choice here would be to have a look laparoscopically and see what's going on. If you don't have access to this, you could inject dye into the catheter lumen, and that can help you sort out a few things. So it depends on whether you have laparoscopic services available, which would be my choice. But if not, you could do a cathetergram or injection of radio contrast dye under sterile conditions in through the catheter and see what you can figure out. And there's a lot of things you can see. I've already shown you the kink in the catheter. You can see if there's a blockage in the lumen. You can get a sense of whether there's an omental wrap by whether there's at some point in the catheter that you can't see the dye coming out of the holes. Or sometimes, especially if the catheter's been put in by a blind technique, it may be that the patient had intraperitoneal adhesions and the peritoneal catheter, unfortunately, was put into a sub-pocket of the peritoneal cavity that was lined by a couple of adhesions. And here's an example of this. This is a catheter dye study, and this dye should spread out through the whole peritoneal cavity. But instead, what you see is that the dye is just in this little pocket here. And that is because the catheter was accidentally put into a subcompartment of the peritoneal cavity that was defined by adhesions. And that is why this particular catheter that was put in by blind surgical technique didn't work properly, and it was diagnosed by this catheter dye study. So with our patient, I really thought that the best thing was to have another look by laparoscopy, and the patient chose to continue with peritoneal dialysis, underwent laparoscopy, and unfortunately, she had an omental wrap. So under laparoscopy, this was removed and an omentopexy was done where it was tacked up in the upper part of the abdomen, and then the catheter worked fine, and the patient was able to proceed with her peritoneal dialysis training. I just want to emphasize that most of these obstructions, especially those associated with omental wrap and with constipation, seem to occur with newly implanted catheters. I'll show you that late obstruction is really quite uncommon. If a patient's on PD for 2 years and becomes constipated, for reasons why I don't understand, their PD catheter still seems to work okay. It just seems to be a newly inserted catheter where it seems to be very prone to outflow problems with constipation, which is why you really have to concentrate on making sure that there isn't constipation in the early period after you put in the catheter. Of course, it's always a good idea to try to keep the patient clear of bowels. And as one of my colleagues says, PD really stands for poop daily. So let's talk about some of the rare causes of late catheter dysfunction. True patient, one of mine, chronic schizophrenia, lives with his mother. You can see his CAPD regimen, and his mother calls a unit to report no outflow of his dialysate. He had been on PD for several years and all of a sudden had no outflow of his dialysis fluid at all. So he came to the PD unit, and true enough, there was no outflow. He felt fine, and we couldn't sample any fluid because there was no fluid to be sampled. And we were all kind of scratching our heads. Why, after all these years on PD, would he have no outflow? So would you change him to hemodialysis, flush the catheter, send him for a flat plate, prescribe cathartics for him, or treat him for peritonitis? What would you do with this patient? So the nurses decided to flush the catheter. It flushed fine, and they sent him for a flat plate of the abdomen, which was fine. So everything looked fine. There was some stool in the colon, but it didn't seem bad enough that he should have no outflow. So what would you do now? Give more cathartics because there was a little bit of stool in the colon? Infuse fluid, inject TPA, catheter lock with heparin, or change him to hemodialysis? Think about it if you were challenged with this patient. Well, the best thing to do was to actually put in more fluid. So 2 liters of fluid was put in, no problem. The 2 liters drained out, no problem. So the final diagnosis was no problem. And it turned out that the patient had forgotten to put his dialysis fluid the night before. And that's why nothing came out in the morning. So, we should have sort of cottoned onto this earlier, but we were really puzzled why there was no outflow, but it had a very simple answer. The patient had simply forgotten to put in the PD fluid. Here's another patient. This really caused us a lot of grief. She had been on PD for many years and had done just fine. And all of a sudden, after 5 years, her daughter called to say that inflow was very slow and the outflow had stopped altogether. We did a flat plate and there was loads of stool in the colon, but the catheter wasn't pushed up. It was in good position. And here I am telling you that for some reason, catheters that have been in for a long time don't seem to be as prone to dysfunction with constipation, but maybe this was an exception, and why all of a sudden now there was all this problem with inflow and outflow. So here's a patient who's been on PD for 5 years and all of a sudden has all this problem with inflow and outflow. What would you do? Would you arrange for catheter replacement, flush the catheter, treat for constipation, or change her to hemodialysis? Now, unlike the new patient who usually has some sort of residual kidney function, so you have a few days to figure out what to do. In this case, she had been on PD for 5 years and was essentially anuric, and really had, we didn't have a lot of time to try to figure out what was going on with this patient. So we flushed the catheter, and there was indeed a lot of resistance to inflow and no outflow. So we gave cathartics anyway, despite what I said about the constipation 5 years in, but there was no improvement in either inflow or outflow. Could everyone please mute their Zoom unless you're going to ask a question or something? So what would you do with this patient now? And we decided to arrange for catheter replacement because we just didn't know why all of a sudden there was all this problem. And we really had to do something quickly because it was now a couple of days in and the patient was anuric. So she was booked for an urgent catheter replacement. And one of our experienced PD nurses, and again, experienced PD nurses are just the gold of a PD program, suggested maybe to replace the transfer set. So just to remind you about the transfer set, this is what it looks like in the catheters that we use. And these transfer sets should be changed every so often, and they can get clogged up with blood clots and fibrin and stuff like that. So we changed the transfer set and we just flushed through the titanium connector and there was perfect inflow and perfect outflow. So the whole grief for the inflow and outflow happened through the transfer set that was clogged up with fibrin. And we certainly learned our lesson. First of all, how important it is to have experienced PD nurses and how we almost ended up replacing a perfectly good catheter because in fact the problem was with the transfer set. So we certainly learned our lesson, and the first thing we do now is to replace the transfer set when there's problems with inflow and outflow. So certainly an important lesson for us. So the clue that something weird was going on here was that, as I said before, these kinds of temperamental catheters occur way more with the newly placed catheter, not in someone who's been on PD all those years. And certainly with this patient, Mrs. W, once we replaced the transfer set, she continued to do fine on peritoneal dialysis. So like I said, an important lesson. And this is an epidemic that we had This is a patient who had a new catheter put in and had two-way obstruction. And when the nurse tried to suck and flush to get out a fibrin plug, it was really, really painful for her. She couldn't stand it. So she underwent a repeat laparoscopy. And I don't know if you can see this, but here's the PD catheter right here in the laparoscopy. And this is the fallopian tube. And it has grabbed onto the PD catheter and occluded it. And in 1 year, I think in 2016, we had 4 patients with 5 episodes of fallopian tube blocking the catheter. Remember, the fallopian tube catches eggs for a living. So it's got myofibril contractile elements. And these contractile elements can contract over the PD catheter. I think it may even search it out the way the omentum tends to search things out. So I almost swore that I was not going to put PD catheters in women anymore because we had this epidemic of these fallopian tubes. So that's something else to consider. And it is something that probably is best diagnosed by repeat laparoscopy. And going in, you may have to pre-consent the patient whether they agree to removal of the fallopian tube, or else it can just be temporarily removed. And because we had 5 episodes in 4 patients, you can imagine that, in fact, in one of the patients, we removed the fallopian tube off the catheter, but then a few months later, the same thing happened again, and the fallopian tube again occluded the catheter. So keep that in mind, especially if the suck and flush is hurting the patient. Speaking of PD hurting, it shouldn't hurt. And this is a man who chose to do cycler dialysis, and he had IgA nephropathy and was approaching end-stage kidney disease and came in for cycler training. The flows were fine, but he had pain with the last 300 mils of outflow. It was left-sided and it really hurt. And so outflow pain is a common problem, especially with cycler PD. At least with CAPD, it's gravity drain, which is more gentle. But with cycler, it's a pneumatic drain, and that can tug on the viscera by the Bernoulli effect. And that can be painful for the patients. And a very neat way to deal with that is either to use CAPD, switch the patient to CAPD, or if they still want to stay on cycler dialysis, is to use tidal PD. And I don't know if Dr. Crabtree talked about tidal, but the idea is that you don't drain out all of the fluid each time. So for example, 70% tidal would mean that the first dwell is 2 liters, but then instead of draining out 2 liters, you only drain out 70% of it, which would be 1.4 liters. And this can be done not as accurately, but at least estimated on CAPD also. If that last little bit of CAPD drainage is hurting, the patient just stops draining before it starts to hurt and then puts in new fluid. It won't be as accurate as on cycler, but I don't think it's a big deal. But tidal dialysis is really important for people who are having outflow pain, and how much tidal you need really depends on when the pain starts. If the patient has had a lot of pain and is very scared about this, I will even do 50% tidal, which means 2 liters goes in and just drain out 1 liter, 1 liter in, 1 liter out, 1 liter in, and so on, just so the patient gets out of the pain cycle. And then you can gradually untidal over time to get more efficient small solute removal. Sometimes too, outflow pain is made worse by our friend, and that is leaving the constipation. outflow pain. And then also sometimes outflow pain gets better with time. And again, I don't know why, if the body gets used to the catheter or whatever, and you can start untitling if you want to. In other words, go back to full volume inflow and full volume outflow. A different point is inflow pain. And again, just like you need to think about whether you're dealing with one-way or two-way obstruction, if a patient is having pain with PD, you've got to figure out, is it inflow or outflow? The inflow pain can be the jet effect of dialysate hitting the viscera. And that was one of the reasons, besides a mental wrap, that some people choose to use a coiled versus a straight catheter, because there may be less of this jet effect. Some people seem to be sensitive to the pH of the conventional dialysate. As you know, conventional PD fluid is acidic with a pH somewhere around 5.2, and they seem to be sensitive to this. That would only give inflow pain, not outflow pain, because within a half hour of dwell, the pH will neutralize and become the same as body pH. So this pH business is really only as a cause of inflow pain. And if the PD catheter is being placed too low in the pelvis, then the fluid going in may be hitting the pelvic floor or the bladder, and that's another cause of inflow pain. And this is something you have to discuss with whoever is putting in your PD catheters. So you can use tidal PD for inflow pain. That way the new fluid coming in is flowing into an already existent residual volume of fluid and not hitting the viscera. If the patient's on tidal, you may want to change to CAPD and have a slower infusion rate. If the patient is sensitive to the low pH of the fluid, you could add bicarbonate to the PD fluid just before infusing it. Or if you have access to the so-called biocompatible PD fluids, you could use pH neutral fluid. But again, this is only for inflow pain, not for outflow pain, because the pH doesn't apply to the outflow pain. Here's a patient, true story, who had an unrelated reason to his PD. He had recurrent kidney stones. Anyway, he had chronic kidney disease, had an uneventful insertion of a PD catheter. He was trained on cycler, everything went fine, and unrelated to everything, he presented to the emergency room with renal colic. And he had an x-ray done because of the renal colic, which incidentally showed that the catheter was up in the left upper quadrant. We had no idea, and interestingly, despite the catheter being up there, he had perfectly good inflow and outflow. Maybe because he was on cycler at night and was lying down when he had his PD. And maybe if he was sitting up, then there would have been a different story. But this was found basically incidentally, that he had this catheter in a bad position. So the question is, what would you do? And I think the short answer is, if the catheter is working okay, I certainly wouldn't do anything. The other thing is, maybe if you give the patient cathartics, the downward peristalsis of the descending colon may pull the catheter down with it. I don't know. But you know what? We have sometimes incidentally found in a PD patient where imaging was done for another reason, that the catheter was in poor position. But if the catheter is working fine, I wouldn't do anything about it. Another important point is that you have to communicate with whoever is putting in your PD catheters. And that includes badly placed exit sites. And I'm sure Dr. Crabtree showed you pictures of exit sites under a pannus of fat, or so low in the abdomen that the patient couldn't take care of it. If the catheters aren't working well, if the catheter is placed too high in the abdomen and therefore puts it at risk for a mental wrap, if the catheter is too low in the abdomen, as I mentioned before, leading to infusion pain, If they're leaking a lot, maybe the surgeon isn't putting that purse string suture in the deep cuff. And like I said before, a kink in the catheter is really inexcusable, and the surgeon has to test for flow before saying that the catheter has been successfully inserted. The surgeon also has to communicate with the nephrologist. And when Dr. Penner, my laparoscopic surgeon, has his 1 OR day a month, he sends me and the PD nurses a debrief. And he will say, for example, if there was a bloody procedure because he had to lyse a lot of adhesions and there was a lot of blood, that the catheter should be flushed sooner than later, and don't be surprised if there's blood in the effluent. That's really important because everyone gets scared when there's blood in the effluent. So if he forewarns you that it was a bloody procedure and not to be surprised, that really is very helpful. He might say that the patient had very poor abdominal tone and that there's a really high risk of leak, and maybe the catheter should not be used and the patient should not be trained for a few more weeks just to allow for extra time for catheter healing. So it's really important to have this kind of two-way dialogue with whoever is putting in your PD catheters, and it has really been crucial to the success of our PD program. And I'll just leave you with this from one of our home dialysis fellows who has gone on to enhance a PD program in another hospital. And it's really a nice approach to catheter dysfunction. And like I said, the first branch point here is one-way versus two-way obstruction. And if it's both two-way obstruction, poor inflow, poor outflow, think of an intraluminal problem such as a kink or a clot. If it's the more common outflow problem, the commonest cause is constipation, and you should deal with that first. And if not, think about things like omental wrap or fallopian tube wrap and things like that. And those are things that can be figured out with a repeat laparoscopic exploration to try to fix it. So really, in the early days of PD, there's a lot of upfront worrying until you know that the catheter is working all right. But I can promise you that it is worth the upfront worrying, because once you get the patient on their way with PD, it is just a pleasure to look after these patients. And with that, I'll stop the talk, and I'm happy to take any questions or comments that you have.
Thanks, Dr. Bargman. I would start with one question. Do you see some complications more often with a certain type of catheters? For example, swan neck catheter versus straight catheters or coiled catheters?
So we've only been using swan neck coiled catheters, I'd say, for the last 15 years or so. So I really can't compare. There is some stuff in the literature, but I think it's not very reliable data at all. The problem with the swan neck catheter is that if you do want to insert a trocar to try to deal with intraperitoneal problems, it's harder to maneuver around the given bend of a swan neck catheter. But we don't tend to use radiologic intervention. But if you do in your center, then it might be better to use a straight catheter instead of the swan neck. The only advantage of the swan neck is that you have a built-in downgoing exit site, which again, I'm sure Dr. Crabtree talked about, is probably better in terms of reducing the chance of exit site infection. But if you have someone who can use a straight catheter and still have a downward going exit site, then you could use that too. I don't feel strongly about it. And I'm not so convinced that a coiled catheter is better than a straight catheter in terms of omental wrap or inflow pain, but that's just basically what we use. Does that answer your question?
Yeah, sure, yeah. Yeah, because we were actually trying to figure out like which based on the data? Like, should we go ahead with the swan neck catheters or the straight catheters? So yeah, that answers the question.
Yeah, so again, it depends on whether you can only deal with interventional radiology to try to straighten out catheters, in which case maybe a swan neck catheter would not be the best one to use. So it depends on what your facilities are like. I wouldn't go by meta-analyses or anything. I really think the biggest prediction of success of the catheter is who is putting in the PD catheter.
Okay, I thank you so much, Professor Bargman. I see Professor Numan Tarif has a raised hand, and then I have a couple of questions. Professor Numan Tarif, if you're there, can you ask your
Yes,
question?
thank you very much, Professor Bargman. It was an excellent lecture, and it cleared so many things. And I still remember many of the things that you mentioned. The fibrin clot, we pulled out one of the patient, and it worked. But the most important point I think that you have mentioned again and again is a good PD nurse. And that is, a gold, a gold person in your team who can take care of the whole program and look at this decision making. That's why we have been having regular sessions for our PD nurses, and some of the PD nurses are actually in this webinar right now. And they have learned a lot, and they feel their importance. Thank you very much for this, please.
Thank you.
Right. So there's a question in the chat box. The first one is, can you comment on incremental PD? Do you believe in that? Yep.
I'm a passionate believer in incremental PD, and maybe you'll invite me back and I'll give you a talk about that. The majority of our patients now, we start on an incremental program. If you have access to Peritoneal Dialysis International, the journal, we have a recent report of our experience with incremental PD. And, of the last 200 patients that we started on PD, about 170 of them started on incremental PD. And, by several years into incremental PD, only about half of them needed to have their dose of PD increased because they kept residual kidney function. So I'm a big believer in that, and I would be happy to talk to you about it more in another session, or you can have a look at our report in PDI.
Very, very kind of you, madam. So I note one of our interventional nephrologists, Haroon Ayub, has his hand raised. Yep. Haroon, if you're there.
Yeah. Thank you, Dr. Bargman, for the wonderful talk. So my question is, do you have any experience regarding the buried PD catheters, number one? And number two, your opinion regarding the urgent start PD?
Yes, okay. So first of all, with buried catheters, so it's interesting that originally the philosophy behind buried catheters was to let the catheter heal in a sterile environment. So, nothing came out of the patient. It was all subcutaneous, and you let it heal up, and then you could exteriorize the external part some weeks after and use it right away, and you wouldn't have any problems with infection because everything healed subcutaneously. So that turned out not to be the case, and the incidence of infectious complications were just as high with buried catheters. In fact, with the stab wound that you needed to exteriorize a buried catheter, there was a report that there were a higher incidence of exit site infections because you used a stab to exteriorize the catheter. So the original intent of buried catheters didn't pan out. But interestingly, people said, but you know what? This kind of has the PD catheter there ready to go when the patient needed it. Kind of like putting in an AV fistula ahead of time before a patient needs to start on hemodialysis, allowing time for healing, and then you're ready to go when the patient needs to start hemodialysis. So all of a sudden, the buried PD catheter became kind of the equivalent of that. And all you would have to do is exteriorize the catheter. Everything's healed up, and you could start with full volume peritoneal dialysis. So That's why buried catheters became popular. Now, I must say, in other places in my province, Ontario, such as Ottawa and Peterborough, they use buried catheters all the time. We tried it for a while. We had about a 25% primary non-function rate with buried catheters. And I think it must be related to technique. And although I've got a brilliant laparoscopic surgeon, for some reason, the buried catheters, they just didn't work well when we exteriorized them. So I just really kind of gave up on them. Again, coming back to what Nayar said at the beginning about the demoralizing experience of exteriorizing a catheter and having it not work. It just wasn't worth it to me. So we basically abandoned the embedded catheters, but that's just our own experience. And like I said, if you spoke to my colleagues in Ottawa or Peterborough, they seem to have a different experience. So that's the story with the buried catheters. In terms of urgent start, we have done that. We now have an interventional radiologist who does a great job of putting in PD catheters, and we will use this especially in patients with cardiorenal syndrome. And we'll put in a catheter and start urgent start. I wouldn't use this. Let me just clarify about urgent start. If you have a brand new patient who comes in and has a creatinine of 20 and a potassium of 8, and they're in pulmonary edema, I would not use PD for that patient unless you had no access to hemodialysis. Because the last thing you want in that setting is for the PD catheter not to work, because it's an emergency situation. So I don't believe in emergent start PD unless you have no access to hemodialysis. Urgent start to me is someone who you need to start PD in the next, let's say, weeks. And that's where you can put in a PD catheter, let it heal for, again, depending on your judgment, a week or a few days, and then start low volume PD. And there's lots of literature on this. It is successful. You do have a higher risk of leaks when you start PD sooner rather than later, but PD leaks is not the end of the world. And you can sometimes finesse this by keeping the patient in a supine position and using low volume. So, and I think compared to having to put in a perm cath, if you can do low volume urgent, not emergent start PD, that it is a good thing to do. Does that answer your question?
Yeah, perfect. Thank you very much.
Okay, thanks.
Yeah, so just a couple of comments. I think what Harun was trying to allude to is that the problem with in Pakistani nephrology is that most of the time patients who go for urgent start PD are the ones which have actually crash landed because they've had 2 fistula failures, perm cath has already been put in, has failed, and now everybody sort of said that no, you don't have access. The patient will try conservative care for 7 to 10 days and then will show up at your clinic or in your hospital with a creatinine of 20 and a potassium of 7. So in that case, PD, I mean, there's no other option apart from PD at that point.
Absolutely, absolutely.
Yeah, absolutely. So that is actually a problem we see very, very frequently in Pakistan, unfortunately.
So, you know, I mean, in that setting, who cares about a leak, right? I mean, the patient's going to die. So you might as well put in the catheter and do low volume PD, just enough to take the edge off. It's not going to be brilliant dialysis at the beginning, but it will save the patient's life. And then over time, you can gradually build up to a regular dose of PD.
Okay, excellent. Thank you so much. So just a couple of more comments, then we'll come to Rasib. And some Zoom user has said that he has found less infections with leaving the patient dry for a couple of hours every day to approximate the PD membranes for a few hours. Has that been your experience? Question mark.
You know, that's really interesting because I don't know if you've ever noticed a nurse changing an intravenous bag. Let's say a patient has a bag of normal saline running and the bag empties and you've got to change the bag. The nurse just comes, pulls the spike out of one IV bag and puts it into the other. No one's gloved, no one's masked, and the patient doesn't get bacteremia every time a nurse changes an IV bag. Contrast that with PD, where, you know, you have to glove and mask and wash and everything. And probably the risk of peritonitis with exchanges is higher because you've got all this sugar solution in the peritoneal cavity, which is like a growing medium for bacteria. Plus, as your questioner is saying, it disturbs the normal peritoneal defenses. So that may be why patients on PD are more prone to peritonitis with bag exchanges than people are prone to bacteremia with IV bag exchanges. So your questioner is saying maybe you should leave the peritoneal cavity empty for a little while every day to just reconstitute the normal defenses of the peritoneal cavity. I'm not aware of any studies of that. It's going to be inconvenient for the patient unless they want to use those 2 hours to have a meal and eat without PD solution. So, and I don't think 2 hours empty is really going to have a big deal in terms of adequacy of dialysis. So it's a reasonable thing to do. It's just, I really can't comment on it. And I don't know if it does reduce the risk of peritonitis, but like I said, it's a reasonable approach.
Okay. Just one more comment from my side. On my own, actually, in considering it is a resource-limited country, what we've noticed is you know, because it's the start of you know, November and we're moving into December, so it's starting to get a little colder here in Pakistan. And the problem comes that, you know, the PD fluid, you know, it gets cold. So when we start putting it into the tummy of the patient starts shivering. We don't have a lot of warmers. What do we use a lot of blankets to sort of warm the PD fluids up? Is there anything you can sort of advise us about? Because the patient keeps on complaining that the PD fluid feels very, very cold nowadays.
I don't know if people can access things like heating pads, whether that would be doable or not, but some people have warmed their PD fluid with heating pads. Microwave is not recommended, and, you know, oven also is a bit of a risk. But so we've had patients use heating pads to do that. And by the way, some patients who live in the hot countries say in the hot weather that they like to use unwarmed dialysis, which really is like a whole new version of central air conditioning.
Okay. One more thing is that, can I ask about, you said that you can change you can add bicarbonate to it. Is there a, you know, formula that you use, or you just add an ampule if you've got an inflow pain to make it more neutral? Or
We have a formula. I don't remember it, but because it's in our list of protocols. Okay. And so, you know, if a nurse calls and says that the patient is having inflow pain, we'll either use, we have access to pH neutral PD fluids now, and that's about the only time I use them, is to try it in people with inflow pain. But if you don't have access to pH neutral, you can use the bicarb. And I don't remember the formula, but we've got it. And if anyone wants to email me, I can get you the formula that we use. It's just enough bicarb to neutralize the pH in the fresh bag.
Thank you so much. I will definitely contact you through your email, and I think I'll circulate that as well with the rest of the groups. Rasid, do you want to say something? You have your hand, please.
Yes, please. Thank you very much. Thank you, Dr. Bargman. It was an enlightening lecture. I thoroughly enjoyed. I have a small question for you. In all your experience, I would just like to know one thing, that in a patient with newly placed catheter, is there a specific guideline to start him on APD after placing the catheter, or you can start a patient on APD right away? Thank you.
I think it depends on the patient and the urgency of the dialysis. So again, if it's an elective start for dialysis, the longer you can wait, the better to ensure healing. And then again, this is what I was talking about, the feedback from the surgeon to you, is that, you know, the patient's got good muscle tone. You can probably start sooner than later. But a lot of our patients are old and diabetic and deconditioned. And, you know, Dr. Penner will tell me that they had basically no abdominal musculature. And therefore, in that case, if it's not urgent to start dialysis, I think the longer you wait, the better, to allow for better healing and less chance of leak. So it's a combination of the two.
Thank you very much.
Thank
So
you.
I just have a couple of more questions and then we'll definitely let you go because I know I've been taking too much of your time. So,
No, that's
so
okay.
this, yeah, two comments from University of Pennsylvania. So Umar Farouk is joining us from there and his comments are number one. So he thinks at their unit, I think the Moncrief or bedded catheters weren't working, but I think that's more of a comment that they will start considering using them again, the embedded catheters. The number two is that in diabetics, do you add insulin to the PD fluid to better control? Yeah.
We used to add insulin to the PD fluid all the time when patients were on CAPD. And certainly for example, patients who have been stabbing themselves with insulin for years, they love the idea of putting it intraperitoneally. So we used to do that. But once we started using cyclers, and the majority of our patients are on cyclers now, not as much as in the United States, but still about 75% of our PD patients are on cyclers. Adding insulin didn't really seem to be very feasible. First of all, it was adding a lot of insulin to the big bags. And secondly, I think insulin is absorbed mainly through the lymphatics, whereas the glucose is absorbed transmembrane. And so you would get fast glucose absorption, a wave of hyperglycemia, slower insulin absorption was followed by a wave of hypoglycemia. And this was described from some studies out of Scandinavia. So we basically abandoned intraperitoneal insulin when we moved to cycler dialysis. If you're using mainly CAPD, then certainly that's a reasonable thing to do. You just have to make sure, remember, every time you inject insulin into the bag, you have a break in the sterility. So it has to be done under very careful conditions.
Excellent. Any other comment before we start thanking our guest? No. Okay. So from our side, actually, it's a very, I'm very thankful to Professor Bargman. It's really humbling and it's an honor and a privilege for us all to be in your presence. I haven't gone, actually, I had a lot of comments and most of it was fan mail for you. That, so that says in the chat box that, yes, she is the best. So fine. So I'll definitely forward that to you. Nayyar, if you want to formally thank Professor Bargman. Thank you so much from our side.
Yeah, thank you very much, Dr. Bargman. And also a comment that you, in your presentation, all of the options of giving up the PD and switching to hemodialysis, you actually ruled that out. So that shows your passion about the PD. And also sometimes we are unnecessarily switching the patients from the PD to the hemo. So what do you say about this?
What's that?
I was saying that you in all your presentation, you said that don't switch from PD to hemodialysis. So
yes,
that's, yeah.
I feel very strongly about that. And like I said, especially if you're not a believer in PD and you're going into it with some reservations, and as soon as something happens, like poor outflow, and you say, oh, that's it, patient can't do PD, and it's just so much easier to put in a perm cath and not have to go through this kind of algorithm that I'm showing you on this chart. So there is like a higher rate of startup worry with PD, and you have to resist the easy option, which is just to stick in a perm cath and forget about it. That's the point I wanted to make.
Yeah.
If I may just add just one small comment. So Dr. Qamar Khan from the United States has just commented, probably it is in reference to incremental PD, that do you use 3 exchanges per day in any of your patients? And if that's what they need, yeah.
Oh yes, our go-to starting incremental regimen, if they're on CAPD, is 3 exchanges a day. If they're on cycler, we'll do 3 times 1.5 liters overnight, day dry. That's our go-to starting. And in a lot of these patients, they keep their residual kidney function for years, so they continue on that kind of a regimen.
Okay, excellent. That's fine. Yeah.
Okay, Dr. Bargman, it was really a pleasure to have you on our webinar. And we will continue to have you in our future webinars as well. It's really nice that in this early in the morning on Sunday, you gave us this presentation. It's really nice of you.
Thank you for inviting me.
Very, very kind. Thank you so much.
Okay, thank you. We'll let you go now.
Bye.